Good afternoon, ladies and gentlemen, respected chairpersons. So after the fantastic talk by Dr. Sengupta, we understood how to assess diastolic dysfunction, what is the difference between diastolic dysfunction and diastolic heart failure. And many things are being developed in the field of diastolic heart failure for the diagnostic point of view. But we must understand, if we diagnose something, we must treat it. If we do not have a solution, if we do not have a solution for a particular condition, then actually the evaluation and all actually will be in vain. So last 2 to 3 years, I can see the evaluation part, as well as we are actually looking more into finding new cases of heart failure with preserved ejection fraction. This is because now we have something to offer to our patients. So initially it started with ARNI, though you all know the ARNI overall, the results of Paragon trial were negative. But later on subgroup analysis, it was found that in mid-range heart failure, or in some sexual difference was there in female, the benefits actually were observed. And then came the SGLT2 inhibitors, initially empagliflozin, Emperor Preserve trial, then we do have delivered, the top line is out. Next month only in ESC, the full trial data will be available. So I'll be briefly touching upon the salient aspect of therapy. Now, patient characteristic, as we all know, heart failure, preserved ejection fraction and reduced ejection fraction are not same. We can clearly see the difference. We can see the preserved ejection fraction heart failure, it affects mostly the elderly. So average age is more elderly, more common in female compared to males. And if you look into the comorbidities which are associated, they are more commonly found in heart failure with preserved ejection fraction, hypertension, diabetes, ischemic heart disease, renal failure, obesity, very importantly atrial fibrillation, and chronic lung disease, COPD. They are more commonly found in heart failure with preserved ejection fraction section compared to the reduced ejection fraction. Rather, reduced ejection fraction heart failure, they have specific etiology. Either they had acute coronary syndrome, idiopathic dilated cardiomyopathy, myocarditis. So more specific etiology are there for reduced ejection fraction patient, whereas the comorbidities are actually more commonly found for patients for heart failure with preserved ejection fraction. Now, if you look into the cardiac pathophysiology, then we'll find mostly at one arm, there is impaired relaxation, and in the other arm, there is increased passive stiffness of the myocardium. Why it happens? To be honest, we do not know whole of it, but we can speculate. There are many pathophysiology, there are many results as well. So chronotropic incompetence we can find. In some point of time, we can see actually the preserved ejection fraction may lead to reduced ejection fraction as well in long term. And the newer aspect, as Dr. Sengupta was mentioning, there is something called left atrial cardiomyopathy, isolated left atrial cardiomyopathy, isolated right ventricular cardiomyopathy. So RV dysfunction, PA pressure, some role of pericardium. These are the newer things, newer avenues which are being evaluated in this heart failure with preserved ejection fraction. If we try to decode how these newer molecules, they are working, particularly the empagliflozin, we have the full trial data with empagliflozin in the form of Emperor Preserve. Then we'll find there are many postulation. Some of them, they say that molecule is actually working upstream. So cardiomyocyte oxidative stress reduction. So in reduction of systemic inflammation, and some of the mechanisms, they work in the downstream, cardiomyocyte stiffness reduction, reduction of extracellular matrix remodeling, the concentric hypertrophy which is taken care of. So these are the different postulations, but if we look at the overall result, empagliflozin could reverse 59% of the protein alteration relevant to heart failure with preserved ejection fraction patients. So that becomes important. So I was looking into the literature when I was allotted this topic. I found this original article was published in this month only, month of July. So it talks about the ECHO assessment and effect of 3-month only, 3-month treatment with empagliflozin on left ventricular global longitudinal strain and myocardial mechanoenergic deficiency. And it was found that only after 3-month trial of empagliflozin, both these things can be taken care of, and there was a significant improvement. So not only we can diagnose with ECHO, we can actually monitor the improvement, we can evaluate the improvement with the therapy with the help of echo, and these modern echocardiographic parameters becoming very, very important, and lot of research are actually taken care of. So echocardiography, if we talk about, this is the echocardiography conference. So what are the parameters which are important? One is very important, left ventricular mass index. We all know about it, but the literature says, the evidence says, it is actually a supportive parameter. We cannot diagnose someone with the only help of echocardiography, but there are different parameters which we can look for. Relative wall thickness, this is important. Left atrial volume index, this is becoming very important. Left atrium nowadays become a very important thing to be assessed properly by echocardiography. Capital E by E prime is somehow standardized, because probably this parameter most widely researched parameter, and this has shown to be a 78% sensitive and 59% specific for detection of heart failure with preserved ejection fraction. Now, tricuspid regurgitation velocity at rest also now are given importance. Pulmonary artery systolic pressure, very simple thing to be assessed by echocardiography, may have very high specificity for diagnosis of heart failure with preserved ejection fraction. And there are some different scoring systems are there. How do you diagnose a patient of heart failure with preserved ejection fraction? This is one of the scoring system, H2FPEF. And you'll be surprised to see that echocardiographic parameter were given less importance. Rather, the clinical parameter, the body mass index, was given a point of 2. A paroxysmal atrial fibrillation or any atrial fibrillation was given a score of 3. So they became more important. As Dr. Sengupta was mentioning, echo can be normal. Even the longitudinal strain can also be normal. Still, you cannot exclude the heart failure with preserved ejection fraction. Rather, this is a clinical entity. This is a clinical entity, and if we look into the scoring system, more the score, higher is the probability that the patient is actually suffering from heart failure with preserved ejection fraction. So, how do we treat it? How do we treat this condition? Because if we do not have a solution, there is no use of so much of evaluation. So we need to have something to offer to our patients. So the treatment, therapeutic strategy, trial, they started from very long, but unfortunately we can see the majority of them actually failed. So it started with 2003. Charm preserve trial with Candacertan, we can see the p-value of 0.05, very narrowly missed, but the relative risk reduction was quite significant, 14%. Then with Irbesartan came I-Preserve 2008 study, the Perindropils trial, which is known as PEP-CHF, which came out 2006, again missed the statistical significance. Digoxin, DIG-PEF trial, again missed. TopCut trial, this is also very, very encouraging trial. We thought this may be a positive trial, but unfortunately, the spironolactone also failed, and the p-value was 0.19 overall p-value. Then came the Paragon trial, Paragon heart failure trial, I was mentioning, 2019. Overall, the p-value was 0.06, very narrowly missed, but subgroup analysis clearly shown in mid-range ejection fraction, particularly if the ejection fraction is in between 40 to 55, there were definite improvement. Also in female, the ejection fraction, even if it is more, there was improvement. So they postulated that probably in ejection fraction, how we are actually measuring in female, that is not appropriate, because the body surface area have some significance in the total overall ejection fraction expression. So those were the postulation, but we thought, we are probably moving in a proper direction. And then came the Emperor Preserve trial, I'll briefly discuss. Deliver trial, already the top line is out. The dapagliflozin has shown promising result. Overall outcome result is positive, statistically significant. We do not have the detail of the trial, but it is going to be available next month only. And then this Emperor Preserve trial. So this is a landmark trial, probably first trial in the history of heart failure with preserved ejection fraction, which was successful. And if we see the endpoint, the primary endpoint was cardiovascular mortality and heart failure hospitalization. It was statistically significantly reduced with a p-value of less than 0.001. So I'll go detail of this, and the secondary endpoint, the first and recurrent heart failure hospitalization, as well as the eGFR slope decline, both were statistically significantly improved. So not only it was good for heart failure, mortality, also it was good for kidney. So this is the overall trial result. The baseline demographic and clinical characteristic, we can see the improvement was not restricted with age, the diabetic status of the patient, sex of the patient, etiology, whether it is ischemic, non-ischemic, baseline NT-proBNP, whether atrial fibrillation, flutter or present, or EGFR of the patient, baseline EGFR, it was independent of that, and it was also independent of the baseline therapy. So overall trial result was good, and as the Paragon trial showed, the group of the patient who had lower part of the, who were at the lower part of the ejection fraction, higher ejection fraction more than 55% was not improving, but in this particular trial, the analysis was done in mid-range ejection fraction and completely preserved ejection fraction more than 50%, both the subgroup actually showed benefit. Both the subgroups showed benefit, but yes, the benefit was more observed in the lower part of the ejection fraction. Number needed to treat in mid-range ejection fraction was 21 only, whereas in preserved ejection fraction more than 50%, it was 42. So yes, impact was more in case of mid-range ejection fraction, but overall the preserved ejection fraction also improved over with the statistical significant results. So there was consistent benefit in cardiovascular mortality and heart failure hospitalization, risk reduction with empagliflozin based on sex, diabetic status, EGFR, whether presence or absence of atrial fibrillation. So all the subgroup, they had similar kind of benefit. That was wonderful part of the story. And very importantly, the benefit was observed very early, similar to all heart failure trials with SGLT2 inhibitor, whether it is DAPA heart failure, Emperor reduced heart failure. We can see it is very clearly that the benefit, it happens very early. The curve started separating very early. In this particular trial, Emperor preserved, the benefit was seen as early as 12 weeks. Only 3 months therapy with empagliflozin, the benefits was observed. So there was no unexpected safety outcome with empagliflozin. This is very interesting because more than 50%, around 50% patients were actually non-diabetic in this particular trial. So the mycotic fungal infection, we can see there was no statistical difference. Bone fracture, all other complications, AKI, none of them were more significant in the trial arm, probably because of more incorporation of the non-diabetic individual. So all the part of the trial were encouraging. There was no additional safety concern in elderly as well. So empagliflozin, many a time people say that it can actually do some electrolyte disbalance, though it is a very novel kind of diuretic, and some of the postulation that potassium might be getting higher, but in this trial it was clearly shown, not only the hyperkalemia, also the requirement of initiation of potassium binder with empagliflozin was actually lower compared to placebo. So almost like a placebo-like side effect. So using ejection fraction to guide medical therapy in heart failure, if the patient is having ejection fraction less than 50%. So heart failure with reduced ejection fraction, we all know there are 4 pillars nowadays: established reduction of mortality in the form of beta blocker, ARNI, spironolactone, and SGLT2 inhibitor. In this particular group also, a new molecule known as vericiguat has shown results, though it is a class 2B indication nowadays. Why? Because there are some restrictions, some limitation of the trial, but still, if the patient is having history of worsening heart failure, what is worsening heart failure? Someone who required hospitalization or emergency visit to a physician for requirement of emergency intravenous diuretic. In those group of patients, vericiguat also showed benefit, and the Victoria trial clearly shown us that, and there is another trial known as Victor trial, because Victoria trial incorporated very, very sick patient with very high baseline NT-proBNP. Victor trial, relatively less severe patient were included. The trial is underway, and when it is out, we can probably have insight how a different pathway can also be taken care of. Now, these are all related to heart failure with reduced ejection fraction. What about mid-range ejection fraction and preserved ejection fraction? There is definite role of SGLT2 inhibitor, because in ejection fraction, even more than 50%, it is nowadays a class 2A indication. I'll show you the guideline and recommendation. There is possible role of spironolactone as well in this group of patient, and if some group of patient, probably ARNI as well as beta blocker can also be tried. So this is the current 2022 ACC-AHA guideline. You can see if the patient is having heart failure with preserved ejection fraction, if there is volume overload, still it is a class 1 indication to use diuretic. Now what next after diuretic? It is the SGLT2 inhibitor. Now it is a class 2A indication as of now, but I'm very sure after next month when DELIVER is out, it will get a class 1 indication for the first time in the history of heart failure of preserved ejection fraction. Some modifying, disease modifying therapy, some molecule which reduces mortality will get a class 1 indication. It's a matter of time only. Now if the patient is still symptomatic, In mid-range ejection fraction, we are supposed to use ACE inhibitor, ARB, ARNI. If not successful, MRA, then evidence-based beta blocker. That is how we should proceed. In preserved ejection fraction, actually, ARNI, it is approved by FDA. Even if the overall trial results were negative, because of lack of availability of the other molecule, and on subgroup analysis, ARNI showed benefit, so it is a class 2B indication to be used in preserved ejection fraction. Then comes MRA and ARB. That is how we should proceed. So I'll finish with this last slide. Heart failure with preserved ejection fraction, stepchild no more. This was the comment by Eugene Brownwell. So on 27th of August 2021, the ESC meeting, Stephen Anker, they actually showed us the Emperor Preserve trial, in which empagliflozin was compared to placebo in around 6,000 patients with heart failure and preserved ejection fraction. The primary endpoint, a composite of cardiovascular mortality and hospitalization for heart failure, was reduced significantly, statistically significantly, with a 21% relative risk reduction. So Brownwell commented that it would appear that finally the dam has been broken and the heart failure preserved ejection fraction is no longer a stepchild. With that, I'd like to finish here. Thank you very much.
Thank you so much, Dr. Arindam. Lovely understanding of heart failure and the new treatment. This session was very interesting, was very informative. We could understand about the heart failure with preserved ejection fraction, and now we are loaded with all the medicines which is available and the new which is going to come. I think we are, I'll hand over the mic to my chairperson.
Can you differentiate between heart failure, preserved ejection fraction, and diastolic heart failure?
Actually, overall, they're same. But if we actually want to define someone, if we want to diagnose someone, if we give a diagnosis of heart failure, preserved ejection fraction, there are three components. First is this symptom, the clinical component. Patient should be symptomatic for heart failure. So all the symptoms of heart failure, we cannot differentiate on the basis of symptom whether he is suffering from heart failure with preserved ejection fraction or reduced. So first of all, they should have symptom. Second, there should be some biochemical evidence that there is heart failure. Now we have NT-proBNP, which is a fantastic tool. And third is some structural heart disease. Find some structural heart disease, we can assess the echocardiography. I showed many parameters. Some of them are more sensitive and specific, some of them are less sensitive, less specific, but you need to have something, either LA volume index, LV mass, E pi, E prime. So these are the three parameters which is there, and patient should actually fulfill all of them. And I showed also there is some scoring system. Scoring system, you can use it for research purpose, but clinically, I don't think it is that much of practical sense, but we should know all of them. Otherwise, symptom plus structural heart disease manifestation by echo and biochemical marker. So these are the three parameters. If that is there, we can define someone to be suffering from heart failure with preserved ejection fraction.
Thank you so much. We have one more question and comments.
Can I have the mic? When we talk in terms of mid-range ejection fraction, that is 40 to 49, that is also now termed as mildly reduced ejection fraction. But I'm not going to highlight these points. The interesting is the profile, longitudinal profile of these cases. A 40 to 49 ejection fraction may be the result of very low ejection fraction improving. So probably patient had 30 to 40 ejection fraction, now increasing, and at the stage of 40 to 49, we are stamping them as mid-range. It could be the other way around. The patient may have a 60% ejection fraction, and the disease process is going on, and the LVF is deteriorating, and has now between 40 to 49, and we're stamping at mid-range ejection fraction. So mid-range ejection fraction could come from two different ends, and that is making it more dynamic and more interesting. Thank you.
Yes, that is very important point raised by Dr. Datta. So someone who is actually coming up with a ejection fraction baseline less than 40% with some therapy, either a CRT, ARNI, whatever, the ejection fraction has come up. Then we call it heart failure with recovered ejection fraction. This is also an established entity recommended by ESC. And we must understand this entity very clearly, because why the patient improved. What was the etiology? That is very important, because if we stop the therapy, say for example, if the patient improved with the implantation of cardiac resynchronization therapy, now if you switch it off, the ejection fraction again will come down. If the patient improved with ARNI and we stop hernia after improvement of that particular etiology, then there is clear-cut evidence that ejection fraction will again go down. So this entity is very important to understand. If the patient is having recovered ejection fraction, all the therapy which resulted in the recovery of ejection fraction has to be continued.
Thank you so much. I like to congratulate on your talk. Just one comment I would like to ask from Dr. J.C. Mohan sir. Anything he wants to add on this? Because he's going to talk about a revolution in heart failure with reduced ejection fraction. Okay. Thank you. So we conclude this session now.
Thank you very much.